The IDSA guidelines on the treatment and management of patients with COVID-19 are designed to support clinical decisions about the pharmacologic management of SARS-CoV-2 infections. They were originally published in April 2020 and have been updated or amended a total of 19 times since then. They are designed to be a, quote, living guideline, end quote, which reflects the critical analysis of available published and grade literature about COVID-19 pharmacotherapy. Currently, 18 recommendations in the guideline cover treatment options across a spectrum of acuity, from ambulatory outpatients to those hospitalized with critical illness.
This graph is a condensed look at the guidelines. As you can see, it's very well laid out and easy to use. The vertical bar on the left lists the various treatment options, while the horizontal bar on the top lists the severity of illness and clinical condition of the patient. The treatments are color-coded for suggested use or suggested against use, with strength of recommendation, and the circle icons display the certainty of evidence. For Domain 1, which looks at the scope and purpose of the guidelines, we gave a score of 89%. The objectives are pretty clear: to identify the best pharmacological treatment for patients with COVID-19. Interventions for this guideline are limited to pharmacological treatment options, with an approach that varies based on severity of disease and setting. Populations are classified as ambulatory versus hospitalized, with need for supplemental oxygen, or hospitalized without supplemental O2, versus hospitalized in critical care. We did not find specific applications that considered other population characteristics, such as gender, age, race, comorbidities, socioeconomic class, etc. Although there was a discussion about COVID infection and multi-system inflammatory syndrome in children at the end of the guidelines. Domain 2, stakeholder involvement, got a score of 58%. This score is more reflective of the specificity of the guidelines in regards to the AGREE tool rather than a failure of the guideline. All the group members were identified and their roles were defined. The views and preferences of the target population were not specifically sought out because they were not really pertinent. Information about outcomes was obtained by a systematic review of peer-reviewed literature, and the grade approach was used to make recommendations. This methodological approach was modified according to the Guidelines International Network McMaster checklist for the development of rapid recommendations. The intended use of this guideline is to, quote, support patients, clinicians, and other healthcare professionals in their decisions about treatment and management of patients with COVID-19, end quote. The IDSA is explicit in saying that this guideline is intended to inform patients, clinicians, and healthcare policymakers, but because of the quickly changing information, should not be regarded as standard of care and should not be used in place of individual clinical judgment. Domain 3, which addresses rigor of development, received a score of 86%. Search methods include Ovid, Medline, and Embase. There were no restrictions placed on language or study type. A list of search terms and methods are provided in the supplemental material. The authors sought RCTs of pharmacological treatment effectiveness. When RCTs were not available, case studies, case control studies, and observational studies were utilized. Each study was reviewed by at least 2 authors. Outcomes studied included mortality, clinical progression or improvement, virological clearance, and adverse events. Where applicable, data were pooled using random effects model. The graph on the right shows how the authors rated the quality of evidence and determined the level of recommendation. As previously mentioned, the grade method was used. Benefit and harms are discussed in nearly all the recommendations, and all the recommendations are applicable to practice. For all recommendations, the panelists reached consensus. Voting rules, which were not described, were used for situations when consensus could not be reached. Regular, frequent screening of the literature takes place to determine the need for revisions based upon new data. When necessary, the entire expert panel is reconvened to discuss potential changes. Patient-important outcomes were prioritized in consideration of benefits and harms, such as mortality, development of ARDS, need for non-invasive or invasive ventilation, clinical improvement, and severe adverse outcomes such as death and disability. Additional drug-specific harms were evaluated when clinically relevant, including possible drug-to-drug interactions. Using systematic review and horizon scan, 2,030 references were reviewed, of which 48 were used as evidence for the recommendations. Using grade methodology, recommendations are labeled as strong or conditional. The The recommendations in this guideline are based on evidence from the best available clinical studies with patient-important endpoints, most of which are RCTs. When the panel was not able to determine that a net benefit outweighed a potential harm based on the evidence, this was considered as a risk of harm rather than potential benefit. The panel urges enrolling more patients into RCTs in order to gather more data.
Continuing the topic of the rigor of development, we found some of the details of the external review process missing. Although the IDSA Board of Directors Executive Committee reviewed and approved the guidelines, and SHE provided endorsements, any specific contribution, change recommendation, or influence either body had on the final guidelines is not mentioned. We did find that the criteria for updating the guidelines is clearly delineated. Updates are based on the availability of new evidence as opposed to a set time interval. We noted that the guidelines have been updated 19 times since April 2020. Our average score for clarity of presentation was 75%. In general, the recommendations are very easy to follow. An exemplar recommendation best illustrates the clarity of recommendations, caveats, management options, and population-based recommendations. Recommendation 8. Among patients who have been admitted to the hospital with COVID-19, the IDSA guideline panel recommends COVID-19 convalescent plasma only in the context of a clinical trial, citing a knowledge gap. Although each recommendation does not state an intended goal, the guideline authors elaborate on each recommendation after the summary statement. Goals of care can generally be assumed to include prevention of hospitalization, reduction of morbidity, and improvements in mortality. The domain of applicability is covered in the following 2 slides. This is where the guidelines diverge the most from the AGREE tool checklist. As can be seen on this slide, no consideration is given to the application of these guidelines at the facility level. Because of this, we scored the domain with an average of 71%. We did note, however, that the purpose of these guidelines is to support clinical decision-making, not to advocate for an institutional change for their own implementation. Continuing the discussion of the domain of applicability, we note that when using the AGREE checklist, we can only credit the guidelines for providing an easily usable summary of recommendations. This is done over 5 pages at the beginning of the document. Furthermore, the guidelines can be credited with employing a uniform definition of clinical severity, one based on the need for supplemental oxygen and/or ventilatory support. We found that funding information and conflict of interest disclosures were readily available. These guidelines were funded in part by a grant from the CDC. The grant number is included in the funding section of the guidelines. Conflict of interest disclaimers include a list of which panel members have potential COIs and with whom or what. The panel chairperson and a majority of the members are noted to be without COIs. We found no specific statement that outside funding or conflicts of interest were non-influential on guideline development. This domain averaged a score of 83%. Our overall assessment of these guidelines is that they serve their intended purpose well. These guidelines are designed to support real-time decision-making in a clinical setting unlike any we have ever faced. Tragically, there is no cure for COVID-19. As providers, we can only offer treatments aimed at suppressing the hyperinflammatory immune response to the SARS-CoV-2 virus. Unfortunately, these treatments are not specific for COVID-19. As such, some treatment options are more effective than others. The clinical climate, the literature supporting various treatments, and the virus itself are all rapidly changing. Therefore, we feel it is necessary to have a treatment guideline that can evolve in response to this. Although no consideration is given to the feasibility of obtaining the recommended pharmacologics, nor to the implementation of the guidelines at a facility level, we feel these omissions do not detract from the intended purpose of providing evidence-based treatment options to healthcare providers. This guideline offers a high-quality analysis of available options and is presented in an easy-to-follow manner. We recommend its use to our colleagues and would make use of it ourselves. When using the AGREE checklist to assess the reliability of these guidelines, we found important sections missing. Little insight can be garnered into how the panel reached consensus, or what, if any, feedback or suggestions came out of the external review. Furthermore, no consideration is given to applying the treatment guidelines at a facility level, nor is there any analysis into the difficulties that facilities may have experienced attempting to implement them. Finally, recommendations are mostly written for a homogeneous population without regard to the variability of disease on age, sex, and comorbidities. With that in mind, we suggest that much of this omission is functional. We think our colleagues should consider these guidelines in the context of how a military officer may consider a field manual during wartime. These guidelines are utilitarian. Their intent is to narrow down the amount of hastily published research to a navigable list of treatment options which frontline workers can access in real time. They serve this purpose well. Were we to suggest that they be remodeled to satisfy the entirety of the AGREE checklist, we suspect that the new version would be less approachable and less practical. The panel members suggest more aggressive recruitment of patients into RCTs, as well as more studies of at-risk populations. They further suggest that research studies have standardized measures of acuity, such as evidence of end organ damage as opposed to hospital location. They also suggest that primary outcomes should be more standard across studies. These improvements would make comparative analysis easier and more accurate. We agree with these suggestions. This concludes our presentation. Thank you for your time and attention.